Hello everyone, my name is Bagashma. I'm ENT doctor for Central Hospital of Mongolia. I have been an ENT doctor for 6 years. Patient 54 years old woman, chief complaint, bilateral hearing loss, more right side, bilateral tinnitus, not allergic, not dizziness, not vertigo. Patient history. Tympanic membrane perforated of left side in 2010. Forced tympanoplasty of left side in May 2010. Otitis media with diffusion of left side in 2013. Then autarkia and autarky of right side in 2014. Bilateral tympanoplasty in December 2014. Otitis media with diffusion of year, 2 weeks after tympanoplasty. Revision tympanoplasty of right side in November 2017. Otitis media with diffusion of right side 2 to 3 weeks after tympanoplasty. Revision tympanoplasty left side in May 2020. Then otitis media with diffusion of right side 1 month after tympanoplasty. And fat graft myringoplasty of left side in 2021. It's media with diffusion of right side 1 month after. Surgical findings normal, ossic normal, non-granulation tissue. Can you see both here? Right side tympanic membrane total perforation, tympanic membrane total perforation of left side. Can you see laboratory findings? She was treated for antivirus in 2016. Can you see temporal bone CT scan? So there is fluid in corner septum of mastoid, and same. Patient Puritan audiogram findings in 2019. Moderate to severe hearing loss of right side, moderate left side. ASSR findings 2020. Mixed bilateral hearing loss, moderate to severe of right side, moderate of left side. Can you see tympanogram findings? Blocked Eustachian tubes, both sides. Puritan audiometry in 2021. Bilateral severe mixed hearing loss. Diagnosis bilateral chronic otitis media, bilateral severe mixed hearing loss. With otitis media, with diffusion, both sides. Thanks for your attention.
Thanks for speaker Dr. Baguma for representing. And so let's discuss about the second case report as you, Dr. Osingha, wish. So.
Okay. Can I talk? Okay. Well, so these patients, well, first of all, we have to see the temporal bone CT. About a year ago, 2020 April, the right side, the mastoid is relatively like a pneumatized, while the left side, epitympanum and mastoid was filled with the like a soft tissue densities. Am I right?
Yes, sir. That's correct.
So yeah, and then when I recall the image of the tympanic membrane, it looks like right side tympanic membrane is nearly total perforated,
Yeah.
and the left side is like a small perforation, but
Yes.
there is definitely some like inflammatory changes on the tympanum as well.
Yeah.
So this patient has a chronic ear in both sides. And
Yes.
then even though she had several operations before, I think still we can have a chance to correct the problems, like to do the tympanoplasty again on the right side. The problem is what might be the possible tissues that we can use for the membrane, because you already have this several operation. So I don't know what kind of tissue you have used. Was it a tympanic, the fascia, temporalis fascia, or was it you use the perichondrium? That depends on. Which side first? That's another question. I'll go for the left side first because left has a more severe. And then definitely left side, it seems like you have to have more large operation. Just other than a tympanoplasty, maybe you have to do mastoidectomy. If I were you, I will do some canal wall down mastoidectomy to correct the inflammatory condition first. Okay, canal down operation was more favorable to control the inflammation, especially this case. This case has a several operation, like a several tympanoplasty, but never success. So go for the left side, chronic ear surgery, using canal wall down mastectomy. And then what about the hearing gain? That depends on your audiometry test. Again, in your audiometry test, I cannot see the speech audiogram. So that speech audiogram really helps us that whether or not this ear is like indicated for the hearing reconstruction or not. If there is a very poor like a speech discrimination, I would not go for the hearing reconstruction surgery. But if there is more than 60%, 70% of speech discrimination, then it depends on the ossicular chains. So I will do some ossiculoplasty, or even without ossiculoplasty, I still need to apply hearing aid after once the ear problem, inflammatory problem was solved. So that was my suggestion for the left ear. Then go for the right ear afterward. Well, I'm not, your hearing right ear is much, well, right ear side hearing was poorer than the left side. Then maybe you have to go for the right side first. That, well, that is questionable. But anyway, yeah, that's my suggestion. I think I wanted to hear about Professor Park, Sugyong Park, and then Chawon Koo about your opinions for that. Who goes first?
Park, go first.
Okay.
I agree with Dr. O, because the both mastoid cavity is relatively small and the sigmoid sinus is anterior displacement, so the intact canal mastoidectomy is very difficult for this case. So canal wall down is good for the yeah, I agree with Dr. O, because the osmastoid cavity is a small cavity, so the canal wall down mastoidectomy is the final solution for this case. And maybe the hearing problem is not so hearing is not just for ear problem, uh, maybe so another those or allergic and another must be asked for her. Is there any problem or other sleeping uh, uh, sleeping habit that must be checked that problem. That's it.
I have an opinion. I thought that it was a graft failure. I mean, the surgery was okay, but the graft was failed and reoperation, or graft was successful, but the middle effusion was kept collecting after successful surgery. Either way, maybe the patient need to be checked about eustachian tube function. So if the patient eustachian function is okay, but the reoperation and keep discharging, then maybe the eventual surgery like canal wall down mastoidectomy and regraft with fresh and very thin temporal fascia regraft would be an option. But in case it was graft was fine and reperforation after ventilation tube or some fluid collection after successful surgery, then we need to do something else than tympanoplasty, like eustachian tube balloon dilatation or some other, or if it is not available at this time, just put the ventilation tube insertion and wait. So that is my idea in this patient.
Okay. As the speaker said, the patient has showing the no abnormality to the eustachian function, and
So Valsalva was
yes,
good.
Valsalva was normal. Yeah,
I see.
and there's also some questions from the audience. How about the swab, ear swab for the otorrhea? Is it necessary, or just is it showing? Can it be showing some effective result to diagnose this kind of disease?
Sure, any discharge from the ear, maybe we should take maybe some pus. The bacteriology should be confirmed and maybe choose appropriate antibiotics before and after surgery.
Yes, textbook wise, that was correct. But in reality, actually, we usually use antibiotics and then ear drops time to time. And actually the swab does not give any conclusions sometimes. So yes, in textbook wise, yes, we have to do swab, but in reality, maybe we cannot get any answers from that. Top on that, actually, even though you're doing swab, that swab pass through the external ear, like a skin. Easily you can have the contamination of the pathogens. So that is another things that you have to be very cautious about the belief about the answers from our microbiological test. So that for me, I think antibiotics is of course is important, but more important is actually the regular and then the very delicate dressings and then ear drops. That is more important. So you have to clean up as much as possible. And as for the mastectomy, if I continue my work, my talk, actually the left side, you didn't show like a whole temporal bone CT. So it's very difficult to say that. But when you compare the right and left side, actually the right side's mastoid cavity is somehow the larger and more pneumatized than the left side. So we can discriminate for the solution for both sides, between these two different sides. I will go for the, I will do the canal roll down on the left side, but on the right side, maybe we can do the another tympanoplasty rather than mastectomy. That depends on. But anyway, before this surgery, I will go for the another round on temporal bone CT and I will decide. But the good sign is this patient shows a Valsalva. That is a good sign for us to that. But before you start your surgery, you have to clean it up, dry them for at least a month. That's the basic things. If you have a draining ear, do not perform any surgery. You will be failure. Okay.
There's also two more interesting questions rise up, and one of them is the patient is also presenting some liver dysfunction, the liver cytosis, like ALT and ALT elevated. Does that somehow related to the graft failure, sir?
I'm sorry, I couldn't follow you. I couldn't follow you. What was that?
The patient was also suffering the viral hepatitis, and with some ALT and AST elevation. And is that somehow relation between the fat graft or whatever graft failures? And the second one is the patient never suffering with the pulsaturia and also just the pulsatile effusion. So what do you think?
So the first question was the viral positive.
Yes,
Is that related to this patient problem? Well, basically, I think it's a different story. I cannot see the kind of the connection between this viral. Of course, you have to be very careful while you are doing the surgery. But actually, still you can do the surgery. You can clean up. But if you have a viral, this is hepatitis, okay? Then when you do some like when you give the when you choose the antibiotics, you always have to have the consult with the internal medicine guys. What kind of the drugs, if this drug can have any problems with the livers or something, that you have to check with them. So that's the things that you have to see. I cannot recall. What was your second question?
The second question was the patient was never suffering with the pus artery. I mean, arteria with the pus. She was suffering with the pulsatile effusion arteria.
Yeah, that if you have a large amount of pus, large amount of discharge, that discharge was bulging
especially that sign was happening right after the surgery 2 weeks later.
That's mainly because I think it
happens all the time. It happens all the cases.
Well, that's maybe the hygiene, post-operative cares, hygienes, where she is taking care of, one, she has a dressing in a local area, and then also maybe she was not very, the cautious about, the shampooing, the hairs, waters in the ear while she's, showers or something. That can be contaminated. It can be easily, initiate the contamination. So after the surgery, usually the patients should not have any pain. But if the patient shows a pain in the ear, sometimes fever, there's definitely postoperative infections. That infection usually, if you perform the surgery with some pus or with some active inflammation, you cannot avoid any inflammation after the surgery. But if you do your every effort before your surgery, like clean it off for at least a couple of months, so you make your all the support. And then if the patients come with any inflammation like that way, that is a problem after the surgery. So you have to very strong and very strict instruction to the patients. Be careful about waters, and then careful about kind of the inflammations or like contaminations. That might be the things. Some patients are not very cautious. Some patients does not care any. So they do just wash their hand, the hairs, and then, oops. Maybe that's my answer. I don't know any other opinions.
Yes, maybe I agree. And maybe we sometimes we have to do surgery even active infection was going on, because tried antibiotics of different kind over several months. Maybe in such case, we need to prescribe the vancomycin over some higher, more stronger antibiotics. But at least we need to try, we need to do our best to minimize the positive charge just before surgery. And then during the surgery, maybe the remaining eardrum or some before we put the temporary, maybe the margin of the canal side should be clean, like some granulation tissue cover the temporary fascia. Then the granulation or mucosa will grow up over the whole the fascia. So that is another trivia we need to remember before when we're doing surgery. Yeah, that's all.
So the lesson from this kind of multiple surgical cases, first, before you go for the surgery, you have to make sure that ear should be dry up. Okay. Well, maybe there are some cases you have to do inevitably, the surgery. In my case, I only do the surgery when the patient has a kind of cholesteatoma. Then, antibiotics cannot, remove the cholesteatoma. Anyway, you have to go for the surgery. But if there's no cholesteatoma, like this kind of simple otitis, you always have to your best to perform, the cleanup, dry up the surgery. Dry up the ear before the surgery. And the second lesson is after the surgery, you have to have the very routine procedures, how to clean it up, and then routine like instruction to the patients and their families, how to care about their ears after the surgery. If that's not guaranteed, you always have the patients come back with the inflammation, like draining ears, and then failure. So that is most important things, okay? So you have to make sure that this kind of principle should be followed in every cases.
There's the last one, the question that arises from the audience related to this patient. The patient is a nurse at our hospital, and she has a good hygiene after all of her post-operative management.
Okay.
So that's the reason why I'm asking. It is the last question, and that's why I'm asking. Is it before the surgery, she always had the dry ears. Of course, this is the one thing that we have to remember before performing surgery, ear surgery. That's the number one criteria. So that's why we're asking. That's the last question. So what do you think? So she has a good hygiene after post-operative care, and tried all the antibiotics, all the ear swabs. There was all.
Okay.
Yeah.
How long do you keep the packing? of the external ear after the surgery?
실 어떤 2 weeks.
2 weeks, okay.
Yeah.
When you remove all the packings after 2 weeks,
Okay.
how's the condition of the drums that you implanted? Was it clean at the time, or was it already, destroyed or, perforated?
It was with the pulsatile fusion. After the
Already?
dressing removal, yes, it's already pulsatile fusion.
I mean, but when there was a packing for 2 weeks, you cannot
Yes.
see the drums anyway, okay?
Yes, after the
After you packing out,
yeah.
very first time, how the drum looks like. If the drum look clean, then surgery, and then after 2 week, management was successful. But if
Yeah.
drum was not good, and then also there's some, already the discharge over there, then you have a contamination during the surgery. Yeah.
Oh, okay. As the surgeons who performed the surgery, as the surgeon said, the after the package removal of the ear, the eardrum was looks okay, but it was there was noticing some of pulsatile movement of the implanted graft, and after the few days later, there's some, of course, there's a fusion comes out.
So the drum looks okay, but drum was pulsatile. Looks like there was some effusion or some, the inflammation in the middle ear. Was it
Is it
freeze?
also is it also related to the too much use of coffee, or I know it sounds yes, because she's using too much coffee, at least 8 to 10 cups of coffee. So
Well,
we're
I had
just
more. I had more. Okay.
Okay.
I don't think so. Yeah.
Okay. Thank you
Let's
for
do it again. But next time, I think for the left side, I think the canal down I will recommend. But the hearing on the right side, I mean, she has a poor hearing on the right side. And I think you have to see her discrimination, okay? How much of percent that discrimination. So you have to decide the real kind of the expectations of a hearing after your surgery. That I couldn't see your data, so please do that. Okay. Okay.
So
Can you move to the final case?
yes, we can, sir. And can we check the another question from the audience? Maybe I need to translate some of our conversation to the audience because some have there's the language barriers. So if you don't mind, sir. Okay, now we have to move on to the final case we will discuss. Also, I'm welcome to the Dr. Bagma to present final cases.
Patient 56 years old man, post-operation tympanoplasty of left side, high tone hearing loss of right side, profound mixed hearing loss left side, bilateral tinnitus. Right side is severe, mild of left side. Patient history. Tympanic membrane perforated in 2007. First tympanoplasty of left side in 2017. Left side tinnitus started in 2016. Mostly tinnitus gets worse when environmental noise but decrease during sleeping. Sometimes mild tinnitus of right side. The left sided of otitis media with diffusion was diagnosed and treated 2 times in 2018. Can you see temporal bone CT scan? This patient pure tone audiometry findings 2016. Single-sided diff of left side. 2017, Puritan audio. This is ESSR findings 2016. Puritan audiometry 2017. High tone, hearing loss of right side, profound mixed hearing loss of left side. ASSR findings in 2019. Profound hearing loss, mixed profound hearing loss of left side. Right side is normal. Tympanogrammy findings in 2019. Right side is A type, left side is AS type. Puritan audiogram in 2021. High tone hearing loss of right side, profound mixed hearing loss of left side. Thanks for your attention.
Thanks for Dr. Beckelman. So let's move on to the session that discusses about the final cases.
So what was the question about this case?
The question about is related to the tinnitus condition. Well, her tinnitus gets worse when she's in the noisy area, but it gets better and it gets low to the when she's at the non-noisy area. And that's
Okay.
the specific of this patient.
What is the job of this patient? 56 years old, male.
She was a teacher, and now she's off duty. Yes,
She or he is a male.
Sorry, sir.
Okay. Well, according to the history, actually, he got an operation at so he started postoperative tinnitus. He started his tinnitus. He had an operation on 2017, but before that, 2016, he started the tinnitus on the left side.
Yes,
and then actually the hearing on 2016 shows that the left side, the hearing was very poor. So when you do the operation at 2017, that was not for the hearing gain. That was for the tympanoplasty only. Am I right?
2017 тавлаа ихтэй тимпанопластийн амжилттай болохоос яг hearing gain болоог үстэй. Нөгөө сонсголон сайжирсан гэдэг хаалгана. There's no improvement after tympanoplasty on 2017.
Did you intend to improve the hearing, or did you do the tympanoplasty just for to close the hole?
Сонсгол сайжруулах зорилготой хаалгыг хийсэн үү эсвэл зүгээр нөгөө sealing буюу бүр зүгээр хаах зорилготой хийсэн. It's just for the purpose of closing out the
Okay, so hearing was already, the left on the left side, and then his problem now is actually he started his tinnitus on the left side before, but now he has more tinnitus on the right side. Am I right?
Зүүн талаас л одоо баруун тал нь илүү шугантай байгаа. No, it's more on the left side, as the doctors say.
Okay, the first slide shows that there is a bilateral tinnitus. It's severe on the right side and mild on the left side.
Oh,
Your slide, the first slide.
It was on the left side. It was the miswriting on the slide.
Okay.
So, sorry.
So basically, okay, let me summary again. He lost his hearing on the left side first before 2016, and he had the operation on 2017. Now the operation was successful with no discharge. So he has a clean tympanum, but that operation is not for the hearing gain. So he has no hearing on the left side, and he continues his tinnitus on the left side. Am I right?
Yes, that's correct, sir.
Then what's the problem? This is just normal.
Yeah, it looks normal, but the specifics that the treating doctor noticed from the patient is the tinnitus issue. She
Okay.
managed all the standard treatment for the tinnitus, but it never gets better.
Okay, on the left side.
Yes.
Yes, the most successful tinnitus treatment for these patients is a cochlear implant on the left side.
What is that, sir?
Cochlear implantation on the left
Yeah,
side.
yeah.
Yeah.
Okay.
Otherwise, tinnitus will be wax and wane. It depends on his job, his stress. When he's fatigued, he's stressful, his tinnitus will become louder. When he get better, then tinnitus will be more tolerable. So it's a wax and wane on his left side. Of course, you can you can apply the bone conduction hearing aid or like a bicross hearing aid for these patients, but that is not for the tinnitus. That is for the not binaural, but anyway, the overcome that single side deafness. But tinnitus itself, the cochlear implantation is only one solution. Otherwise, it will just stay there. That's my opinion.
Before to go to the all the way to cochlear implantation, I think we need to confirm how about the patient hearing. Actually, the hearing 2019 left side bone conduction looks normal, and the conduction is full conductive hearing loss on the left ear, and on temporal bone CT, the middle ear aeration is okay. But the surgery seems to be wrong because the graft should be under the malleus handle, but eardrum is intact, but malleus is far from the eardrum. So it is natural. The result is full conductive hearing loss in this patient. So I would be better to do surgery of tympanoplasty again to medialize the eardrum and under the malleus handle. And before that surgery, maybe need to check the hearing. Bone conduction is if it is okay, and if there is a purely sensory neural or mixed.
Yeah, that's correct. So that's why I keep saying that you have to have the speech audiometry.
Okay.
So the next slide on 2021 June, that shows a profound hearing loss. So your hearing test is somewhat unreliable. So unless you do some speech audiometry and then they check that whether left side bone conduction is still available or not. So if there is some bone conduction over there, and then speech audiometry shows us like a more than 50, 60, 70% of speech discrimination, the Professor Ku's suggestion was quite useful, that because the eardrum graft is far lateralized, it's not contact with the malleus handle. So that might be the first thing that you can do surgery again, only after your speech audiometry shows the kind of the valuable things. But if I see this audiograms on 2021, I will not go for the tympanometry because it seems like his hearing is already gone on the left side. So that's the definite question that you have to find the answers.
There's the question from the audience. is that possible to be temporal bone fibrous dysplasia?
Why do you believe that?
I don't know. It's from the question from the audience. So.
Well, when I see the temporal bone CT, it does not look like a fibrous dysplasia. If you have a fibrous dysplasia, it's quite asymmetric and ground glass like bulging masses. So this temporal bone CT does not match it with this kind of disease.
So, but the on temporal bone CT, the temporal bone is very what is it? Calcified, ossified, quite ossified the temporal bone. So maybe it does not form a mass like a fibrous dysplasia, but the aerated temporal bone was ossified, and that's why the mastoid is contracted, and the temporal bone, tympanic bone, is way ossified.
Well, yeah. I'm now going back to my temporal bone CT. I'm seeing that maybe I was wrong. Yes. Yes. Well, that on the left side looks like the mastoid is a little bit thicker. Yeah, and hazy. Yeah, I think I'm still looking for that. Maybe. How old is he?
56
56.
year old.
Well, yeah.
But it does not matter. Maybe
Yeah.
it does not narrow the ear
Yeah.
canal, and it does not deform ear.
Yeah, it's not a clinical, like the indication for this surgery by itself. Yes. So yes, I'm seeing that. So let's check the hearing again, and then make clear that whether or not these patients really have the mixed hearing loss or profound hearing loss or conductive hearing loss. That is the first thing you have to discriminate.
Okay.
Okay.
To discriminate by using the speech audiometry, so,
Speech
right?
audiometry and repeat of the Puritan audiometry as well. Yeah.
Okay.
And then, yeah, then you decide. That the lateralized TM, even though I don't know whether you have the intentionally performed surgery like that way. That's the as Professor Koo mentioned, I think you always have to make sure that the tympanum, the replacement, should be under the malleus handle. If you have it seems like a thick cartilage you have on the lateral side of the tympanum. It's much lateralized. This is for the controlling the ears. So that's why I asked that when you have the operation, and then before the operation, was the hearing was normal or not, or good or not. But this operation seems like that is not definitely for the hearing gain. Okay, so if you have any kind of surgery to reconstruct the tympanum as well as to improve the hearing, you always keep in mind that your tympanum graft should be under the malleus handle. Okay, not lateralized. So this happens when you have the onlay operation instead of underlay operation.
Yeah.
Okay, that's the technique.
And now, please, sorry. Thanks for all of your magnificent feedbacks to all the visiting professors. And now, it's also it was a great constructive feedbacks, ideas, and advices, and also we're appreciating to all attendees who actively participated. Now we're just finishing off representing all the cases we have to discuss, and now there's the local deputy from the Raffle Foundation who will say some statement before we're finishing this webinar. So please. Deputy Inc, please welcome.
So yes, Dr. Kang and
Okay, I'm here, sir.
Yes, I think this is our conclusion of today. But before we conclude, I think I would like to ask you that you may have some feedback from your colleagues over there after this one. And then if there's any ideas to improve this kind of things in the future, then let us know that, kind of formats or kind of some, whatever it is. So we can continue to discuss our, the system to improve our discussions in the future. For me, I'm very, uh, grateful to have the discussion today. And then you gave us some, the information before, and then we have time to review your cases before we get into the conference. That was good. And also after this one, we have to summarize our discussion in each side. And then we exchange our idea that whether or not we have discussed in a correct way. And then follow up is necessary for, not every case, but certain, necessary case for the future discussion. And then finally, I would like to ask you that, what is your opinions on then how often do you think this kind of conference should be in the future? Every other month, or in every 3 months, or what is your opinion? What is the idea of your side? If you cannot answer today, you can discuss later.
Yeah. We'll discuss later. But preferring it to be happen on it has to begin on the September. After that, it can be happen on every in a monthly or something like that, sir.
Okay, I heard that you have a long summer vacation, so okay.
Yes, sir.
So next
But we
time
really,
should be the September.
Yeah.
And then okay, we agree that. Okay, we can do this September. Do you agree that Dr. Koo and Dr. Park? Okay.
Yes, I'm fine. And my sabbatical month start in middle of September, so maybe earlier than middle of September, June 15 or June 14. Before that, I would be fine.
June, September.
September 15, 14.
Okay.
Or earlier.
But even in your sabbatical, you can connect to the Zoom, like internet. Am I right? So it does not matter.
I think so, but I'm afraid, but the area is that internet may not be accessible in some situations. I'm going Iceland.
Arctic area. Okay. Okay. Well, okay. We'll discuss that later. The one more thing is, we are all ENT doctors, but today we are focused on the otology. So we can mix up with other specials, like rhinology and head and neck, which I'm not familiar with. So is it okay that we can continue some otology cases for a couple of times or more than 3 times, 4 times, and then we switch to the rhinology or head and neck cases? Then we can invite other doctors, professors from Korean side to that. So ask them to participate this kind of meeting in the future. So
yes, because it takes time, so we have to win the time.
Yeah. So next time in September, we come with some more otology cases. Okay,
Yes.
that's agreement at least this time. Okay.
So about how many the duration of how many times?
How many hours or how many?
I mean, how many times? Like 2 times, or after this session 2 times or 3 times?
Yeah. Yeah, if you have a run out of your cases, then we move to the rhinology cases.
Okay.
Or when we move to the head and neck cases. But at least, even though you move to the head and neck cases, you have to give us some, the kind of slides or information way before the conference. That way, I invite the other doctors to come over to this conference. Okay, that makes us. Okay, so at September, at least we will go for the another otology cases. I think these 3 cases is quite, comfortable for us. It already took 2 hours, but I think we have enough time for that.
It's a comfortable for 2 hours for you.
Yes, yes, at the
Okay.
moment, yeah.
Thank you. It's
Not
great to
every
have this.
time, but I think so.
Yes. But because we're very desperate to need to figure out the confusing problem that we
Okay.
encounter. So
Okay. Yeah.
thank you.
The least but not, the last but not least, Professor Park, will you speak? Comment something before we close?
Thank you very much for having me, and I am also learn very much thing, especially for the first case, and I want to some help for the Mongolian the medical development. Thank you very much.
I think it's all because of COVID. Before COVID, we didn't, think about this kind of conference. But I think because of COVID, and then because of the Rafael International, and also the office in the Mongolia with Dr. Enkajaya, I'm sorry, Enkajaya, then we can have the successful meeting like this way. So yeah, let's continue. And I'd like to thank all of you to participate in this successful meeting. Okay, so bye now.
Bye now.
Okay.
자,
Bye.
독수리
Okay.
Yes. Ciao.
Okay. Our next online discussion is anticipated to be organized on upcoming 14 or 15 September. It depends on the professor's time. And so please feel free to contact and send us or specific cases that you experienced so far. Thank you. Bye-bye.
Well, I'm sorry. 14 and 15, we have a temporary course in our institute. So I think it's better to have 1 week before.
Oh, okay.
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 Yeah,
That's great.
1 week before the 14 and 15, which means that about 9 September 9 is the Thursday, like today.
Okay.
So I think we choose our date of next conference at September 9th.
It's a Thursday. Okay.
Is it okay? Yeah.
Yeah, it's
Is it
okay.
Okay.
Okay. It's great to have you all of you, Professor, who's visiting this webinar. And thank you.
Bye-bye.
Bye-bye. Have a good day.
You too.
Thank you. Bye.
Bye.